So, hello everyone. Very good evening to one and all present here. I am Dr. Jeel Makaria, a medical graduate from Baroda Medical College, India, and I will be the moderator for this conference. So, firstly, I would like to thank you all, each and every one of you, for being here with us today on day 2. So first, let me give a little introduction about Prmp. Can we have the next slide, please? Yeah. So Prmp is a peer research mentorship program, which was started with the goal of providing mentorship to new researchers who weren't able to find a guide. With the completion of 3 rotations of the program, Prmp have now completed 45 research projects with the help of 90 mentors and 980 mentees. Currently, the 4th rotation is about to begin. We have collaboration with the INOS International, Remed Kenya, and the Health Drive Foundation for the peer mentorship. So on the day 2 of the conference, we have the paper presentation competition followed by the prize distribution. For competition, there are 2 rounds. The first one was abstract submission, where the participants send the abstracts, which were then selected by the abstract judges. In round 2, the selected abstracts will present their papers here in the conference. The abstract judges, Dr. Anand and Dr. Al Hassabuzman. Dr. Ayush Anand is an academic editor at the PLOS One journal and the vice president for research at Global Consortium of Medical Education and Research. He was awarded the Best Editor 2022 by Global Journal Medical Students. Dr. Al did his MBBS in Ningbo University and graduated with honors. He has worked with the Purnoto Foundation and is a part of the Bangladesh National Cadet Corps. Now, I would like to welcome our judges for the paper presentation competition, Dr. Maria Gabriel Kaza and Dr. Aarti Shah. Dr. Kaza is a clinical research coordinator at Columbia University Irving Medical Center and a research scholar at Harvard Medical School. She is an adjunct faculty at SPSN and is interested in global health and health disparities. Dr. Aarti Shah is a board-certified pediatrician at Texas Children's Hospital and is a research scholar at Harvard Medical School. She is the secretary of International Medical Graduate Section of Texas Medical Associations. I would now like to invite Deputy Director Dr. Tejas Singla to give the insight about today's competition.
Yeah, thank you, Dr. G. So can I have the next slide? Yeah. So regarding the rules for this round, each presenter will be given 8 minutes for the presentation, and it will be followed by 2 minutes of question answer session. And medium of communication is restricted to English. And please ensure you have internet connection, and presenters will be allowed to share their screen for the presentation. And now regarding the judging criteria, can I have the next slide? Yeah. So each presenter will be judged on the basis of following points that are content, visual appeal, oral presentation, and question answer session. And each category will be marked on the basis of 1 to 5, with 5 being the best. Okay, thank you. Now I'd like to hand over to Dr. Jeel.
Okay. So are you all ready for the presentation? So we will call our first participant, Harshi Bhagat.
Hello, everyone.
Hello. Yeah. Can you share your screen?
Yes.
Okay. So the total presentation is for 10 minutes and 8 minutes is for the presentation and 2 minutes are for the judges for the question and answers. And I will give you a warning when you are 30 seconds left. Okay.
Yes. Can you see my
Shall we
screen?
start?
Yes. Hello, Hershey.
Hello.
Yes, I can see your screen. This is Abdul Hanan. Just a second. I wanted to confirm with our judges that are they ready for the presentations to start?
Yes, I'm ready.
All right. And Dr. Arati?
Dr. Aarti is on mute, so but she said she's ready. Yeah, she's showing her thumbs up. Yeah.
Perfect. Okay.
Good evening, everyone. I am Dr. Harshi Bhagat, and I'm going to present my paper on the topic Can BID6 and BIDL isoforms predict precancerous colorectal polyps, a literature review. The presenter is me, Harshi Bhagat. I am a medical graduate from AMC Met Medical College, Ahmedabad. My co-authors on the paper are Purva Shah, Lajja Gadvi, Charmi Parikh, Pritesh Jakharia, Dhairya Shah, and Parmeshwaram Ramnath. We are from the PRMP group 02/03. And something about me is I'm interested in pursuing internal medicine residency from the US. So starting with the introduction of our paper, colorectal carcinoma is the third most common malignancy worldwide, with approximately 1 million deaths in a year, making it the second most common cause of death due to cancer. The diffuse and non-specific nature of symptoms of CRC often causes delays in diagnosis. Therefore, biomarker detection can aid in identifying precancerous lesions and give better insight into the prognosis of the disease. Biomarkers are biochemical signals which indicate normal or abnormal processes taking place in the body and may be a sign of an underlying disease or condition. One such biomarker of interest is the BCL2 family proteins, which are associated with the apoptosis of cells. This review intends to identify the role of BID6 and BIDL proteins in the early detection of polyps, usually in the preclinical stage, prognosis of CRC, and variations on the basis of age, gender, and tumor location. The methods used for this paper, a comprehensive literature search was conducted using the following electronic databases: PubMed, Google Scholar, Cochrane Library, Science Direct, and the WASH. Our search included papers published from the inception of the databases up to the current year. The search strategy included the use of relevant keywords and mesh words such as colorectal adenomatous polyps, colorectal carcinoma, screening, BID6 and BIDL, and their variations. The search was limited to randomized controlled trials, observational studies, cohort, case control, and cross-sectional studies published in the English language in peer-reviewed journals. Editorials, conference abstracts, case reports, and series and experience pieces were excluded. Paper selection through title and abstract screening and full text screening was performed blindly by 2 reviewers, and in case of discrepancy, a third reviewer made the final decision. This review included patients with colorectal carcinoma diagnosed by endoscopy or histopathological examination. Results. Out of the 1,004 studies collected from PubMed, Science Direct, Google Scholar, DOAJ, 91 studies were included after title and abstract review, followed by a full text review. Due to the heterogeneity of the included studies in terms of design, patient characteristics, and assay methods used, a narrative synthesis of the findings was performed. BID, which stands for BH3 interacting domain death, a pro-apoptotic member of the BCL2 family, acts as an agonist for the BAK and BAX proteins, promoting cell death. Alternative splicing of the BID protein produces various isoforms such as BID-S, BID-EL, and BID-ES, and each has separate functions. The BID6 and BID-L are 2 biomarkers highly upregulated in the adenomatous polyps as compared to the surrounding tissues. The descending colon has the highest expression of BID6, whereas the transverse colon has the highest expression of BID-L isoform. Male colorectal carcinoma patients have increased expression of BID-L as compared to female patients. The studies indicate that higher levels of BID increases susceptibility to apoptosis-inducing ribonucleotide reductase inhibiting medications, thus aiding in the treatment. Now, a little bit about the mechanism of the BID protein. It is started with the activation of the caspase 8, which is activated by the death receptors and TNF-related apoptosis-inducing ligands. The caspase 8 leads to the cleavage of BID protein and converting it into the truncated BID, which increases the permeabilization of the outer mitochondrial membrane, and thus increasing the action of BAK and BAX proteins. It results in the release of cytochrome C protein, which further activates the caspase pathway, thus leading to the apoptosis of the cell. So BID protein has an interaction of both extrinsic and intrinsic pathway. In conclusion, the expression of BID6 and BIDL isoforms is higher in adenomatous polyps and the surrounding non-polyp tissues than in the normal colon tissue, suggesting a relationship between the expression of these isoforms and polyp formation. Further clinical studies can be done to understand the efficacy and acceptance of the screening method and use of BID6 and BIDL as a novel way for diagnosing and prognosis of colorectal cancer. Thank you very much.
Okay. Thank you, Harshi. Now I would like the judges to ask the questions.
All right. Hello, everyone. This is Artisha. I'm sorry I was a bit late joining, but right in time. Thank you very much for the opportunity to be here. So Harshi, thank you. This was a very relevant topic. I guess there is a needs gap. Is there, as compared to the current biomarkers? How does this compare? And is this a blood biomarker that we are looking at, or a stool?
So these
For a pediatrician like me, sorry.
Yeah. So this is a tissue biomarker, which is usually detected after the biopsy and through histopathological examination. So that, and these are novel. This is a novel biomarker which has been recently found out. So and has been founded more in the adenomatous polyps. So we need some more studies and clinical studies and should be done to know more about its relevance and as compared to the current biomarkers which are present, like KRAS and BRAF mutation biomarkers which are present today. So more research and the new proteins like BID can be done to know more, because current ones are there.
Got it. So this would compare to another tissue biomarker, you would say, not, it can't be used as a screening test then? Because of the limitation, because instead of a blood or a stool biomarker, this has limitations. It is a tissue biomarker. So are we looking at it for prognosis mainly? And
it is mainly used as a prognosis method because yes, mainly as a prognosis biomarker. Yeah.
Okay. Thank you very much. Interesting. I hand it over to Dr. Yes. For you.
Dr. Kaza, do you have any question?
My mic. Yeah, sorry about that. Dr. Shah, do you have an additional question? I don't know if I cut you or something.
No, I didn't.
No.
I'm good.
Okay, great. So thank you very much. That was an incredible presentation on colorectal cancer. So I would like to know, given all this heterogeneity of the studies that you included, how were you able to synthesize the findings that were performed with these two type of biomarkers?
So one of the studies performed and done was a study that they did the tissue testing and everything, and and the ROC they did the testing for all the samples they collected from the patients, and according to that they formed an ROC curve which showed that the BID6 and BIDL proteins showed a statistically significant increase in the patients of CRC. So we took those results published in the study to form a hypothesis that this can be used further, and more studies can be done in this area to see if this can be used more widely.
Right. so the idea is that they will use them in the future as biomarkers for the clinical practice, like a routine clinical practice to be used, right?
Yes, yes. So this was a very a study done in a small group of people, which showed a significant statistically significant results. So we tried to find the data and everything and the literature which shows that the increase in these proteins is seen in the polyps. So further studies and further research can be done in a wider group of people to make this tool as a more you make this tool a more widely accepted method for prognosis for and diagnosis of CRC.
Okay, great. Thank you for answering my questions.
Thank you.
Okay. Now, the audience, if you have any questions, then you can write it down in the chat box. So I'll give a moment for the audience. If they have any questions, then they can write them in the chat box. Okay, Dr. Tejas, I would like you to read the question.
Yeah, just a second. Yeah, so Dr. Rohan is asking, why didn't you go for a meta-analysis?
Yeah, so we didn't go for a meta-analysis because the studies conducted in this area were limited, and what we try to do is try to find the gap in the gap in the knowledge, which is which like can BID6 and BIDEL isoforms predict CRC. So we try to find the gap in literature, make a literature review about it, and hence show that more studies and research in this area can be done. And after more studies, a meta-analysis would be possible only after that. So our main aim was to address the knowledge, address the gap in knowledge where BID6 and BIDEL isoforms can be used to predict or the diagnosis or prognosis of the CRC.
Okay, I think that it answered the question. Thank you, Hershey. I would request the judges to write down the scores, and I'll give some time to them. Until then, we will ask our next presenter, Adrika Kashyap, to just join in and share their screens. Judges, are you ready for the second presentation?
Yes.
Yes.
Okay, yeah, you can start.
Okay, hello everybody. My name is Adrika Kashyap, and I will be presenting a study that we did, a review of the efficacy of cannabinoids in Dravet syndrome, and my group number is 0307. So a little bit about me. I'm an intern right now at GSMC and KEM Hospital located in Mumbai, India. My co-authors are Purva Shah, Vinuta Labu, Muhammad Usman, Manasvi Shamsundar, and we don't have any conflict to disclose. So now jumping into it, Dravet syndrome is a rare epileptic encephalopathy, which is a severe form of epilepsy characterized by prolonged seizures, often triggered by hyperthermia. And otherwise, the infants have experienced absolutely typical development. And studies on this show that the prevalence is 1 in 17,000. However, the number is it might not be exact, and it might be in fact understated because of the absence of sizable epidemiological studies done on this syndrome, because it's not very well known. So basically you have, it's like a rare epileptic encephalopathy. Now, recent studies that are done on this syndrome by, for example, Porter Bender et al. Have shown that CBD, which is present in cannabis sativa, might be helpful in managing refractory cases of Dravet syndrome. And our review basically aims to summarize these studies that have been done in order to gain a wider perspective of the use of cannabis in Dravet syndrome. So the methods that we used, we performed literature search using PubMed, Google Scholar, Dawaj, Science Direct for all papers published till September 2022. And we included RCTs, cohort studies, case control studies, and cross-sectional studies that were published in peer-reviewed journals in the last decade in English language, which adhered to the PICO of this study. Now, PICO stands for patient or population, intervention, comparison, and outcomes. So the patients were patients with Dravet syndrome. The intervention was use of cannabinoid. The control were patients on placebo, and the outcome was whether there was any improvement in the symptoms of Dravet syndrome with the use of cannabinoid, which was measured by the reduction in seizure frequency. And we excluded editorials, commentaries, systematic reviews, meta-analysis, and narrative reviews. The risk of bias was analyzed by using Newcastle Ottawa scale for observational studies and ROB version 2 scale by Cochrane for RCTs. This is like what the Newcastle Ottawa scale is for observational studies. The results that we found in this review that we did was we had a total of 15 studies, which included 9 clinical trials and 6 observational studies between 2013 and 2021, sorry. And we studied nearly 2,000 Dravet syndrome patients with a mean age of 11 years. And they were given doses ranging from 0.5 to 10 mg per kg per day as a starting dose to 2.8 to 50 mg per kg per day, which is the maximum safety limit. And they were given this for 2 to 156 weeks. And at the end of the study period, a significant amount, that is 22.5% patients, or for 40 patients, did experience a reduction in seizure frequency. And 2.3, that's 45%, became absolutely seizure-free. Now, some studies did report improvement in sleep quality, alertness, and anxiety, but these were not found statistically significant. Also, what we found when we were conducting this review was that a number of adverse drug events were recorded, with the highest being upper RTIs, pneumonia, flu, ear infection, UTIs, and pyrexia, followed by GIT problems like gastroenteritis, abdominal pain, constipation, appetite changes, and vomiting. And patients also experienced somnolence and fatigue as an adverse reaction to the CBD that they were consuming. And in some patients even reported increased seizure and psychomotor activity and elevated liver enzymes and ataxia as an adverse drug reaction. And as a conclusion, after the review of the studies that was done on Dravet syndrome patients, we found that the cannabinoid preparation used did in fact show a significant reduction in seizure frequency in some patients, with a small number of them experiencing absolute seizure freedom, but more than 50% did have mild adverse effects. However, the number of studies done were few and not very prolonged. So in order to understand completely what the actual effectiveness of CBD is on Dravet syndrome, more placebo-controlled clinical trials are needed. So that's it. Thank you.
Thank you, Adrika. Now I would like our judges to ask a few questions to the participant.
Yes, of course. So I'll start this round, Dr. Shah. So very good presentation, very interesting about the Dravet syndrome and the usage of CBD. But I noticed that within the data that you collected mentions the adverse effects that are actually quite common. They're mild adverse effects, but almost half of the patients that were observed there experienced this. Do you still consider that going through an RCT would be the best way, knowing that we have this evidence? Or what would be the considerations or potential implications that you think that this continuing with an RCT for this type of trial would imply?
Right, so given the adverse drug reactions that were experienced, I think there were not very serious adverse reactions. So I think maybe an RCT would be valid, even though there are adverse drug reactions, because given the fact that almost a quarter of the patients did actually have good outcomes, that is, the seizure frequency did reduce. So I think it's still valid to perhaps continue RCTs on CBD in Dravet syndrome patients.
Well, always when we go for a randomized clinical trial, we have to balance the amount of adverse events that patients may present when using a drug. So this is something that you may want to consider. I think that more data should be collected on this and more observational trials. You always think about going into a randomized clinical trial. You always have to think of patient safety first. And that's what it always will be, patient safety. So just, take that in consideration, but excellent presentation.
Thank you. Yeah.
Thank you, Dr. Kaza. Dr. Aarti.
Hi, thank you, Adrika. And thank you, Dr. Kaza. That was one of my questions as well. So, because we're talking about kids, what did you find as per the literature review? What was the average age range where these, the cannabinoid, and there's such a wide dosing range. So what do you think the dose response curve, even if it's mentioned in the articles or not, what do you think would be the average dose milligram per kilo needed, and the average age? Is there a minimum age cutoff below which you don't want to subject them to any kind of somnolence, fatigue, or respiratory depression?
Right.
Related
Yeah.
to
So especially as we had mentioned, there were adverse drug reactions, which for an adult might not be serious, but for infants might be serious, right? So you have to sort of take that into account. And we included patients that were below 18 years of age, and that's actually a pretty wide range. And the mean of the patients that we studied was 11 years. But so different studies had focused on different age groups, but obviously very severely, like for example, Dravet syndrome is diagnosed only after most probably in like the second year of life, because it begins only after the second year of life, because the infants have to be shown to have a previously typical developments, like in the definition of Dravet syndrome itself. So there were no patients who were in like the first year, because then these adverse reactions would be pretty, serious. And the safety of CBD and given to very, very young patients is still, it's out for discussion. But I think maybe if you go for a safe age from 10 to 18, I think it's the most viable age to go forward with further studies based on, giving CBD. But apart from that, if you go for younger patients, it might not be very wise to conduct further RCTs because, again, the adverse drug reactions like upper respiratory tract infections, all of that might be very severe. Plus, there was even like a few patients who had experienced increased seizure activity, which might be even life-threatening for very young infants. So to answer your question, I think maybe we should focus on patients in the age group from 10 to 18. So if I were to conduct an RCT, I would definitely aim at that.
Well, thank you. And do you think there is any comments on the dose? Because it's a wide range.
Yeah, the dose. So
based on the
again, yeah, so the maximum safety limit for CBD was 50 mg per kg per day. And again, you have to start it off very slow, very minimum amount, so 2.8, and slowly increase it and see if they're acting okay with it, right? And patients who were below 10 years of age, they were given 0.5 mg per kg per day. And we in fact excluded some studies where because they were dealing with such young patients that they had to go below 0.5 mg per kg per day. So we in fact excluded those. But for the dose, I think you should start at say about say 2.5 for if you're aiming at age group of 11, which was our median age, and then slowly increase it and see how much they can take, and like
balance the adverse.
Yeah, up to 50 mg per kg per day if they're not experiencing very adverse drug reactions. So you have to taper it accordingly, I think.
Wonderful. Very, very relevant to the very rare condition, but obviously there is a need for, because it's refractory. So wonderful presentation. I would also look at the exclusionary criteria of the population because some of them could have other, for example, fetal alcohol syndrome or, extreme prematurity as their history. Now, if they're 10 or 11, some of those won't matter or may not, but yeah. And then of course, liver conditions and metabolism of the cannabinoid.
Yeah.
Thank you very much.
Thank you.
Very well done.
Okay. Thank you, Adrika. Now, audience, if you have any questions, then you can write it down in the chat. All right. Thank you, Adrika. Now we have a question from Rohan. Tejas.
Yeah, so Dr. Rohan has asked, like, what about the neurodegenerative effects of cannabinoids?
Okay, so neurodegenerative, there are studies that have shown that there are serious neurodegenerative effects of cannabinoids, but this was done in a very controlled manner. Like, for example, mostly the neurodegenerative effects of cannabinoids that you see are in people who are abusive. Like you can get motor alterations, akinesia, bradykinesia, all of that. But the dose that we used did not, that the studies used, did not go to that level of, there weren't toxic levels of CBD that we used. It was a very controlled manner. And that's why we didn't see the neurodegenerative effects as a adverse drug reaction in the studies that we included.
Okay, I think that answered the question. Thank you, Adrika. Judges, I would request you to write down the scores. Until then, we would ask our next participant, Ramsha Jamani, to just share her screen. Ramsha, are you there?
All right, Jeev, if Ramsha is not here, we can move on to the next
Okay,
participant.
yeah, okay, yes. So we'll ask our next participant, Asma Ashraf Khan, to share their screen. Do we have Ashma here?
Yes, sorry
Okay.
about that. I was trying to fix the screen.
Yeah, it's okay.
Okay. Hello, everyone. Good evening. My name is Asma Shah Khan. I'm a fourth year MBBS student of Dow University of Health Sciences. And my research topic is proton pump inhibitors for globus hystericus. It is a systematic review and meta-analysis. My co-authors are Dr. Purva Shah, Priya Manali, Yuban Khan, Abdul Hanan Siddiqui, Utsaf Pia, Pranita Hulbe, and Zahid Khan. Now, before I get into the textbook definition of globus hystericus, I want everyone to experience what a globus hystericus patient feels like when they have this disorder. Now, suppose you have a medicine or tablet on your tongue and you're waiting for the water, but you accidentally swallow the medicine. That weird, uncomfortable, lumpy feeling, almost like the medicine is stuck in your throat. That's what patients with globus hystericus describe as the persistent or intermittent, non-painful sensation of a lump or foreign body in the throat. It's fairly common both in men and women, and its prevalence is 21.5%. The symptom is prominent in laryngopharyngeal reflux. So that is when your stomach acid goes from your esophagus all the way to the back of your throat, or atypical gastroesophageal reflux disease. So patients that have GERD experience atypical symptoms such as cough, pharyngitis, laryngitis. The objective of the study was, or the aim was to review and analyze the published literature regarding the efficacy of proton pump inhibitors in globus sensation. As for the methods, we went through 9 databases: PubMed, Google Scholar, SpringerLink, Wiley, Cochrane Library, Science Direct, Taylor and Francis, Ovid, and Douage. And we collected the articles from inception until May 2022. The keywords that were used were globus hystericus, globus sensation, globus pharyngeus sensation, globus, and proton pump inhibitors. Included studies were cohorts, case controls, cross-sectionals, and interventional studies available in the English language. And all excluded studies were reviews, meta-analysis, case reports, and case series. As for the PICO, we chose patients that were diagnosed with globus hystericus. The intervention was proton pump inhibitors. The control group either got placebo or no intervention at all. And the outcome was symptom improvement in patients with laryngopharyngeal reflux. Now, after going through the 9 databases, we collected a total of 2,076 studies after duplicate removal, to which we did title and abstract screening and full text screening, and we concluded with 15 studies. Out of the 15 papers, 9 were observational studies, 6 were clinical trials between 2001 to 2022. Sorry, 2020. 5 of the studies were from USA, 3 from South Korea, and 1 each from Taiwan, Germany, Japan, Netherlands, India, China, Tunisia, and Lebanon. A total of 1,046 laryngopharyngeal reflux patients were collected with a mean age of 49.6. The females were about 55%. The mean BMI was 23.69. Smokers were about 22%. 40% were the alcohol addicts, and 72.14% of patients had history of GERD. We selected 3 studies for random effect meta-analysis on the R software. And after analysis, we got an odds ratio of 0.56 and a confidence interval of negative 0.48 to 1.60. So because the odds ratio was less than 1, there was no positive association between proton pump inhibitor and symptom improvement of globus hystericus. The p-value was 0.29, so again, not statistically significant because it was greater than 0.05. After testing for heterogeneity, we had a very high heterogeneity of 84.82% in the I2 test, and the Q test had a p-value of 0.001. So that means heterogeneity was statistically significant. Coming on to the qualitative analysis, we had a total of 64 patients with global symptom improvement that were taking PPI for about 2 to 16 months, either alone or with a combination of antacids, H2 blockers, gabapentin, or prokinetics. When looking at the specific symptom improvements, the majority of the articles talked about pharyngeal improvement, which had global sensation or a decrease in the mucus production, laryngeal symptom improvement, which had vocal changes, chronic cough, or donophonia. There was also improvement in laryngoscopy and esophageoscopy. There was no improvement seen in manometry and 24-hour pH monitoring in one of the studies that it was mentioned in, and 2 studies that mentioned endoscopy also showed no improvement. Overall, symptom improvement was seen in patients that had lifestyle modifications of no oral consumption of PPI 2 hours before bedtime, and a 6-inch head elevation. So when they were sleeping, they made sure that the pillow was elevated enough so that their head was 6 inches in elevation. Patients with abnormal baseline 24-hour pH probe findings and abnormal interarytenoid and vocal fold mucosal findings also showed a symptom improvement. And overall, patients that had a longer duration and higher frequency of PPI dosage showed a symptom improvement. To conclude, although the relationship between the resolution of globus hystericus and proton pump inhibitor in our study was not statistically significant, the meta-analysis on the 3 studies done showed 2 studies that did show a positive relationship, but the overall result was not statistically significant. Qualitative meta-aggregation emphasized the influence of various demographic factors, patient habits, and other investigations that determine the individual patient outcome. For future recommendation, more randomized control trials are needed to further explore the relationship between proton pump inhibitors and globus hystericus. Thank you.
Thank you, Asma. Audience, you can write down the questions right now in the chat. Meanwhile, judges, if you have any questions for her.
Yes. Hello, Asma. Asma, thank you for presenting. It was very well done. So I had actually 3 or 4 questions, but I'll try to pare it down to 2. It mentioned there was positive and negative correlations. So could you, based on your literature review, what do you think could be the negative correlation that what could have accounted for that use of PPI?
I think it was also based on the participant size, because when we did the meta-analysis, 2 of the studies showed a positive correlation. So they did show symptom improvement. But again, one study had a bigger bigger participant or sample size. So that could have attributed to it.
Okay, got it. So it skewed the data. Okay. So secondly, relevant to this, based on the literature review, what do you understand could have accounted for not finding a significant impact? Like it was not statistically significant. Was that related to the patient population looked at with their, other characteristics, including, alcohol consumption and cigarette smoking? And would those have contributed as confounding factors, you think? Or
yes,
what
I feel like patients with disease severity, the more severe the disease, the less likely there was symptom improvement. And those patients that had abnormal findings, they showed a symptom improvement as compared to those with borderline globus hystericus.
Okay, so just to understand you right, there was significant improvement shown if they had more severe disease, right?
Yes.
Could you comment on other factors? So other than the smoking and alcoholism, the perception of the sensation of globus, right, as you defined. Do you think there could have been other psychological factors involved, including if they had anxiety, or was that looked at? So do you think there were confounding factors in short, the heterogeneity of your sample?
Yes, I agree because of the alcohol consumption and history of GERD, and also the data analysis or the data that was acquired was based on questionnaires that were formulated, whether that be reflux index score or reflux finding score. So I think patient's perception would also attribute to the results.
Thank you. Thank you very much.
Thank you, Dr. Aarti. Dr. Kaza?
Yes, so very good presentation. I really like the topic. Could you remind me again real quick, how many randomized clinical trials were performed in total and how many observational trials were performed?
So 9 were observational studies and 6 were clinical trials.
Okay, and you mentioned that the patient population for this trial was not very big, and probably there was some sort of confounding factors that did not provide a lot of additional information that made seem that there's no significant results within the study, correct? So do you consider that ongoing placebo trials would be something, randomized clinical trials with placebo, just methods including lifetime changes, which were actually comparable, give you the comparable results in most of the trials that you have analyzed within your research? Or are there other standardized treatments that could be possibly, explored for this study?
Yes, there were some placebo trials, although the number was very less, but that would be beneficial, especially because questionnaires or the patients are being asked for symptom improvement, and other drugs such as H2 blockers or antacids that again some of the patients were taking in the trials that could have contributed. So maybe comparing PPI treatment to other drugs such as antacids, H2 blockers, or drugs that were used for GERD or laryngopharyngeal reflux.
Dr. Kaza?
Gabby, I think you're on mute.
Yes, sorry about that. Yeah, so do you consider that within the confounders, it might be that some of these patients were taking additional drugs that may have hidden the possible results or factors that would improve the disease? Is that what you're referring to?
Yes, a small percentage were taking other drugs which could have affected the results. So that's why in the future randomized control trials, so even observational, comparing PPI versus other drugs that the patients were on should be conducted to further see the relationship between the disease and the drug.
Great, thank you very much.
Thank you, Dr. Kaza and Asma. Dr. Tejas, I would ask you to read the question, please.
Yeah, so Dr. Mariam is asking, why did you choose Globus and not GERD?
Initially, we did want to conduct the study on GRD, but there was already a systematic review and meta-analysis done on GERD. And there was also a lot of studies on laryngopharyngeal reflux and GERD related to PPI, but limited data available on global sensation and PPI association.
Okay, so the next question we have, was a quality assessment performed for the 15 included studies? And
Yes.
what tools were used for it?
For the randomized control trial, ROB was used, and for the observations trial, Newcastle Ottawa tool was used.
Okay, so we have another question. Like, do you think if studies that used SSRI or any other psychiatric therapy along with PPI, the study would have shown a better outcome in treating globus?
It could be because of that, but again, it's better if we just focus singly on the PPI to see its effect rather than combining other drugs, because maybe the other drugs could cause a change in the results or pattern of symptom improvement.
Okay. Thank you, Asma. I think that answers the questions of all the audience. Thank you, Asma. Judges, I would request you to write down the scores. Next, we have Dr. Rashma Jamani. I would ask to share the screen, please. Okay, here. So judges, are you ready? Yes. Okay. You can start with the presentation.
Sorry, Jill, sorry to interrupt. I just wanted to highlight over here that Dr. Ramsha, she has not presented yet. She was supposed to present on the third number, but Asma presented. So
Okay.
kindly do not confuse the points for both of them.
Okay.
Thank you.
Yeah. Dr. Ramsha. You're not audible.
No, you're not audible, Ramsha.
You're not audible.
If you're wearing Bluetooth earphones, then I would say remove them. And if not, if you're using your laptop or mobile phone audio, you can check it
Audible now?
once again. Yeah,
Yeah.
now you are.
Yes.
All
Now
right.
you're
Sorry
audible.
for the inconvenience.
Yeah.
Sorry for the inconvenience. Okay, starting. Hello, everyone. My name is Dr. Ramsha Abdul Qadir, and the topic of my presentation is prevalence of TB iris among HIV patients, a systematic review and meta-analysis. My group number is 0108. So my co-authors are Siddhant Uchani, Ehsan Rakib, Mohit Bhatia, Purva Shah, Isra Khan, Asish P. George. A little bit about my introduction. I'm a house officer at Dr. Prmp Civil Hospital, Karachi, and I'm a graduate of Now Medical College. Coming back to the presentation, introduction, the immune reconstitution in inflammatory syndrome. It is can occur after initiation of antiretroviral therapy and consists of either the appearance of a new condition or a worsening of a pre-existing condition. It is believed to result from the restoration of the immune system and its response to antigenic stimulation. Approximately, there is 18% incidence of immune-associated inflammatory syndrome among patients with HIV-associated TB. The aim of our research was to know the prevalence of TB iris in HIV patients. Methodology. We have included RCTs, cohort, cross-sectional, and case control studies in our study. Adult patients who are greater than 13 years and have HIV infected with TB and were on previous TB treatment, and then commenced ART were included. Case series, case report, and studies that reported less than 15 cases of TB iris were excluded. We have used PubMed, ScienceDirect, and Google Scholar for our data set, and it was last performed on 17th of October 21. For the quality assessment, we have used John Britt Institute critical appraisal tools, and Revway Studio was used for the data analysis. Out of a total of 885 relevant studies, after the initial search, there was, after going through the Prisma flow chart, 69 articles were left for analysis. The total number of patients were 14,010 HIV patients. As you can see, the overall pool prevalence of TB iris was 13.82, with a confidence interval of 10.67 to 17.7. 0.7. Our p-value was statistically significant and that was 0.01. The highest and the heterogeneity was high, 96.5. For that, we have a subgroup analysis according to the region and study year. When stratified by continent, there was the highest pool prevalence of TB-IS cases in Europe, Asia, and afterwards North America, Africa, and South America. When stratified by the year of publication, there was the highest prevalence in the studies published between 2011 and 22, the continent with a prevalence of 15.93, then the studies published between 2000 and 2010. In order to assess the publication bias, we have used the Prmp plot and it was found to be asymmetrical. That's why we have used the Eggers test and it also proved our publication bias. For the conclusion, this meta-analysis suggests that the prevalence of the condition differs according to continents and over time. However, the significant heterogeneity observed in all subgroups indicates that care should be taken when interpreting these results. And we should reconsider search strategy or grade literature inclusion for the publication bias. Considering the high prevalence of TB iris, further studies looking at how to decrease the rate of iris in high-risk patients appear warranted. Thank you.
Dr. G, you are unmuted.
Yeah, sorry. Yeah, sorry. Thank you, Ramsha. Now I'd ask the audience to write their questions in the chat box. Judges, if you have any questions, then Dr. Aarti, Dr. Kaza.
Yeah, sure. So I have a couple questions. So I know that you mentioned that it was a little muffled, I must say, during the presentation. I don't know if it happened to everyone, so I may have missed it if you said it during your presentation. But what do you think were the factors that make that this disease varies, this condition varies within different continents, within different countries? Did you by any chance mention that, or maybe I did not catch it?
No, I didn't mention that, but I'll answer to no. The possible factors that affected the incidence might be the prevalence of different infectious diseases like TB, TB is especially prevalent in low middle income countries. So that might also affect the prevalence of TB iris in the Asia subgroup being higher. Also, the other risk factors were the CD4 count, the age group, mostly younger people were affected in our studies. The male sex was also a risk factor for development of this. And our response to ART, like if you had a rapid fall of RNA on initiation of ART, then the incidence of getting TB iris was higher.
Okay. My next question would be, I know that within your meta-analysis, you mentioned, there's significant heterogeneity, right? But North America is not mentioned here. You mentioned all of the countries. Do you think that it will be helpful to explore also these potential sources in other regions as well, including North America, to see what's the impact for within the results for this condition?
Yeah, it would be a very good idea to explore it further into North America.
Why do you think that they're not including North American as a meta-analysis? Is there not sufficient observational studies? Because there is population that is in risk to suffer the condition, but why is it that it's not, did you not find enough data on this?
Yeah, we didn't find much of the articles from North America. That's why we didn't include it in our study.
Okay, and my last one. So you mentioned that the studies that you included reported at least less than 5 cases of TB iris, right? But what was the rationale for you to, use this criteria of selection?
I did.
Why do you cut off to 5 patients?
We randomly decided because the initial number of articles we were getting was a very big number. So in order to tailor it down, we use this rationale. There was no specific reason beside this.
Did you help yourself with, any statistical, reason to take this cutoff, or?
No, there was no statistical reason for this cutoff.
Okay, so always when you consider studies, you always have to back up your study with a statistical reason of choosing this. I would say that will be my feedback on that. You never want to present a research saying that, it was just random, we just selected a number. It will be good that within your conclusions, this is the reason why we selected, and it came out because of a statistical reason that we selected to use this cutoff. Sometimes clinical studies would not be considered valid if you just, you just consider something randomly by choosing, like from your own, how would you say this?
My own will.
Yeah, your own
I
will.
got your point.
Yes.
I got your point.
Yes.
We'll improve this.
Yeah. Okay.
Thank you.
Thank you, Dr. Kaza. That was a great help. Next, Dr. Aarti, do you have any questions?
Sure. Thank you. Yes, Ramsha, this was a good relevant for, especially as you said, the low and middle income countries, very relevant, both TB and HIV infection. So thank you for looking at this. And to be honest with you, the immune reconstitution inflammatory syndrome, I had to look that up and see what it, so can you enlighten me on the possibility of iris in HIV negative patients? I see that it's rare, at least from my skimming of the literature. But since you were focusing only on this, why do you think it's only the factors having low CD4 count and the others that you mentioned, the timing, or are there tuberculosis factors too, including response to drugs, for example, the anti-tuberculosis, like the regimen? Are there factors in that which determine how the iris evolves or doesn't, or it's just based on the HIV side of it?
Okay, and coming back to your question, the immune reconstitution inflammatory syndrome is basically the syndrome that occurs after the restoration of the immune system. Like the HIV patients are basically immunosuppressed. So after starting antiretroviral treatment, their immunity begins to improve. So patients who were previously affected with any infectious agent, like I primarily focus on the tuberculosis, but it could be T simplex virus, CMV, cryptococcus, or any autoimmune disease, or especially it could be a tumor, non-Hodgkin lymphoma. So in those patients, when they are getting their immune restoration, so there is a chance that the response to these antigenic stimulation might be there. So that results in the formation, that results in this iris syndrome. Na? So the risk factors I told you, na? One risk factor could be short interval of time. Like if a patient has previously ongoing opportunistic infection, and we had started before the patient was really clinically stable, we started ART. Then there was in literature, there was a higher chance of getting iris as compared to if we wait for the patient to become clinically stable and then we start ART. But there were some exceptions for this, like if the patient had tuberculosis meningitis or cryptococcal disease or CMV retinitis, in those cases, we shouldn't wait for the patient stabilization. We should continue ART and the infectious treatment side by side.
Okay, I think I understand that better now. So thank you for that. Can I ask you a follow-up question? So when you mentioned, so basically if a patient with HIV has tuberculosis as well as pneumocystis carinii pneumonia or other kinds of opportunistic infections, would that be responsible for the, like, are we stratifying based on other co-infections present as responsible for the development of iris, or vice versa for the decrease in the rate of iris because there are other infections or autoimmune conditions involved?
Yes, there are many conditions involved with iris, but the articles we selected were basically focusing on iris associated with TB.
Okay.
So we didn't stratify it because we haven't collected the data. We specifically collected the data with iris associated with TB.
Okay, wonderful. That answers my questions. I just wanted to follow up, make a comment on what Dr. Ikaza had suggested is, yes, if you know that you're going to, exclude it of your own will, then based on the sample size, because you have so much of data available, I would probably not mention it and just include the data that you'd like to include, right? Because you're the presenter, it's your art, it's your hard work and the literature review. So the sample size, if you have enough of, large sample sized, data collection, then you don't have to necessarily mention why you excluded less than 5. That would save you from coming up. That's just my suggestion though. Thank you very much.
Thank you so much. I noted it. Thank you.
Yeah. Thank you, judges, for the suggestion. And thank you, Ramsha, for the presentation. I would ask the judges to note down the scores. Until then, we will request our next presenter, Soumyajit Das, to share the screen. Sorry, I think I missed the question for the audience. Tejas, can you just read out the question, please?
Yeah, so Dr. Rohan is asking, I had previously come across a meta-analysis on the incidence of TB iris in HIV-infected adults in a high-impact journal. So what is the novelty of the current study?
Can you let me know the date of publishing, because we started in September 2021 and we have registered in Prospero for this, and at that time there wasn't any meta or systematic review published on this topic now. Haven't come across.
Rohan, do you have the follow-up question or the answer of this question from Ramsa? I think that was, okay.
Yeah.
Okay, let's continue and we will get back to this question at last.
Okay, sorry for interrupting. I just checked your review, and it is from 2015. And after this review, there were more articles, clinical trials and studies done on this topic. So we have updated this systematic review and meta-analysis was outdated.
Okay, I think that answers the question. We will ask the next participant to present, Soumyajit Das. I would ask to share the screen.
Hello, am I audible?
Yes, you are audible. Can you share your screen, please?
Okay. Okay, it's showing me a problem. It's showing me only the host can share in this meeting. So,
I will make you co-host. Just 1 minute, please.
okay, sure. Thanks.
Yeah. Now, can you try?
Just a second.
Sure.
Okay, so
Judges, are you
can you see
ready
the
for
screen?
the
Yeah, your screen is visible.
visible? Yeah. Judges, can we go ahead with the presentation?
Yes.
Okay. Over to
Okay.
you, Soumyajit. You can start.
Okay, thank you. Okay, so hello everyone. Good evening to all the respected judges and the viewers and my fellow presenters. My name is Shomujit Das. I'm a third year medical student, and I'll be presenting as a part of the PRMP group number 0204. And I'm extremely privileged to be here at the second ICSA annual conference to present my work, which is titled Estimating Children's Weight and Comparison of Pediatric Weight Estimation Methods in an Indian Tertiary Hospital, which is co-authored by Dr. Purva Shah, Binish Aslam, Shankanil Ghosh, and Minmay Kundu. So moving forward, I would like to give a little background of our study. So our study focuses on the crucial need for accurate weight estimation in pediatric emergencies. Inaccurate weight estimations can lead to adverse drug reactions, toxicity, and ineffective treatment. However, estimating weight accurately can be a little challenging, especially in low and middle income nations where reliable infant scales may be scarce. The commonly used age-based weight estimation techniques in India have been found to be a little imprecise, resulting in incorrect medication dosage and unfavorable outcomes. The Breslow tape recommended by the Indian Academy of Pediatrics is hindered in India due to discrepancy between Indian children's weight and the tape's design for the actual American population. Therefore, our study aims to bridge this gap by developing a formula specifically designed for the Indian population, providing the healthcare practitioners with a reliable and more accurate tool for estimating pediatric patient weight in emergency situations. Before moving forward, I would like to highlight the importance of our study. By addressing the limitations of the existing methods and tailoring weight estimating techniques to the demographic and physical characteristic of Indian children, our study holds a great importance for improving emergency care outcomes. Our study seeks to enhance medication administration, fluid management, and equipment selection, ultimately reducing the morbidity and mortality rates associated with inaccurate weight estimation in pediatric emergencies. For the methodology part, our study was registered on OSF to increase the validity and the authenticity of our methodology. We included children between the ages of 1 and 18 years whose parents provided us with consent. For the exclusion criteria, we had children requiring immediate emergency needs, or those with conditions affecting the weight, or those children who were on weight affecting medications like long-term steroids, and children with limb deformities. We had a total sample size of 75 participants who were recruited to ensure an adequate power for the Blonde-Altman analysis and multiple regression analysis with a significance level of 0.05 and a power of 0.80. The population recruitment was done in an Indian tertiary hospital, which I'll mention later. The children were recruited from 3 sources, that is outpatient department, inpatient, and those who came for immunization. For the data collection part, we collected details of age, sex, height, and weight. For the height measurement, we used standardized tapes, measuring tapes like the Ionics inch measuring flexible tape, metal measuring tapes, and for infant height measuring, we use the IS Indo-Surgical Infantometer baby height measuring scale. For weight measuring, we use the standard weighing machine, the digital weighing machine, and for infants, we use the infant weighing machine. The body habitus was measured using a figural reference image adopted from the Popper study. So Our outcomes were that the primary outcome was that proportion of children whose weight was estimated within 10 to 20% of the actual weight by each weight estimation method to measure accuracy. Our secondary outcome was that the precision of weight estimation methods using Blount-Altman limits of accuracy. For the statistical analysis part, we used multiple regression model to derive a new age-based formula with age, sex, and length as variables. Blount-Altman analysis was conducted to compare different weight estimation methods. The statistical analysis was performed using StataB application in Microsoft Excel software. The key noteworthy points from the methodology was that this was a cross-sectional study conducted at Government Medical College in Trivandrum with a duration of 2 months. The data collection included age, sex, height, and weight measurements using specific tools. The outcome measures focus on accuracy and precision of the weight estimation methods. Statistical analysis involves multiple regression and Blount-Altman analysis. Results may have implications for improving emergency care outcomes in pediatric patients in India. For the results part, the study population, which we had about 75 participants with a mean age of 11.13 years with a standard deviation of 4.98. The gender distribution was 48% females and 52% of the participants were delivered by cesarean section. The current mean height, as you can see from the table, the current mean height of the participant was 135.27 centimeters and the mean weight at birth was 2.77 kgs. The mean current weight was 41.43 and the sample exhibited a wide range of body habitus according to the Popper scale ranging from 3 to 6. Now here's what we found. We found a significant difference between actual weight and the Popper scale, indicating that the Popper scale cannot accurately assess the participant's actual weight. Furthermore, the relationship between Popper scale and the actual weight was significantly affected by factors like age, Popper scale body habitus, and current height. Regarding the Popper scale body habitus, the incidence rate ratio for body habitus 3 was 1.24, and for 4 it was 1.441, for 5 1.58, and it increased. Current age also had a significant effect on the relationship, with the incidence rate ratio of 1.04, while gender did not show a significant effect. Thus, in conclusion, the Popper scale is not accurate for estimating the actual weight of children in an Indian tertiary hospital. Age, Popper scale body habitus, and current height significantly influence the relationship between Popper scale and actual weight. Improved pediatric weight estimation methods are necessary for emergency situations in lower middle, and even in upper middle income countries. Thus, future research should focus on developing and validating alternative weight estimation methods that consider age, body habitus, and current height for accurate results. With that, I come to the end of my presentation. Thank you, everyone.
Thank you, Soumyajit. Audience, you can write down your questions in the chat. Judges, I will ask you to ask the questions, request you to ask the questions, please.
Hi, Soumyajit. Thank you for presenting. This is very relevant, especially as you said, because of the lack of appropriate correlation using other kinds of methods, the Brosseler tape as we use in the United States, and the differences in body habitus as well as the correlation based on height. So can you comment on what would be, which population would benefit from using the Popper scale, because it has been used and it shows good correlation. Do I understand that it is basically based on the Indian subcohort that we are finding limitations of use of that based on the body habitus, other factors? Can you enlighten us on that?
The Popper scale is a standardized scale. However, in the Indian context, it's not really relevant, as you can see, because it was originally developed for the American population. So it doesn't take into account the the Indian changes in children and the Indian body habitat structures. So thus, it's not really relevant for the Indian population. Now, I'm not really sure about where it's actually like feasible. Of course, it's feasible for the USA because it's the uh, standardized used scale there. But as we found in our study, that it is not really relevant for India.
Okay, thank you. I think I see European like studies from coming out of Italy and other European countries. So coming back to your presentation and what we are looking at, what do you think other than the body habitus could be a limiting factor here? And why do you think that it's needed all the way up until 18? Did you feel that the data could have been, you could have shown more power or statistical impact if you limit it to the age group where we need to have more accurate, because after a certain body mass index, so to say, there is not a need, or our medications are not necessarily, they don't keep increasing based on the weight. There is a cutoff and then there is a max, right? So do you think looking at the specific age group where after a certain body mass index, then it's not going to show a significant difference using the scale or not, because it doesn't change, the dosing doesn't change necessarily after that? Do you think that could have made a difference? I'm not sure if I'm clear with my question. So my point in cases, or my case in point is that the Popper scale has limitations also, right? But why do you think we need to have something equivalent, or I guess better, for 1 to 18 years of age? It doesn't, like the dosing for all medications don't necessarily keep going up after a certain body mass index. So say a 12-year-old has a BMI of 18, and then we don't have to necessarily know the exact weight of that child for all the medications relevant in an emergency situation, especially, right? So do you think there is a need to develop a new scale for the entire age group that you mentioned, 1 to 18, or do you think that a smaller subgroup would be a better way of showing an impact of, trying to develop a new scale, right? That requires effort.
Hi, Dr. Aarti. I would just like to point out that Somijit's network was not proper. He just went out of and then he came back
Okay.
again.
Hello.
Yes, Somijit.
Yes, Samaj.
Yeah, I'm extremely sorry. My internet is having a little bit of issue. Okay, I heard ma'am's question, and okay. So firstly, I would like to tell that Popper scale is used till the age of 18. So, and we had participants from the year of 1 till 18. And as you said that does body habitus affect the dosage and all? I guess it does, and we need a more reliable tape for this. And so if I'm not wrong, your question was that should we take into account more number of age group? Am I right?
In fact, the other way around. I was going to say, if you're trying to develop a new scale, would you rather focus on the age group where we need more accuracy based on the weight, height, body surface area, body mass index after a certain, cutoff? Then we don't need to base all the medications on the exact body surface area or body mass index. Medications do max out, right? For adults, like you don't keep going up on the dose, right? So many kids between 12 and 18 achieve that body mass index. Fortunately, unfortunately, but they do. So would you rather focus on developing something for the population that's going to actually benefit from it, or do you want to keep it as wide as 1 to 18? Was my question, because you don't necessarily need to know the exact BMI of an 18-year-old.
Right. Okay, that's a really interesting question. Actually, from our study, what we did was we found differences in weight and body habitus. So I guess yes, there is a need, which you said, to actually go for something a larger scope, because yes, children do achieve body habitus higher than their actual, age-based group, what we found. So I guess yes, there is a need.
Right. My suggestion was to, when there is, you determine there is a need. So I guess when developing a new scale, if you were to pursue that, if you focus on a more smaller age group, like the age range, instead of being 1 to 18, if you focus on, like, say 1 to 12 or 1 to 13, that may show more impact of the new scale being developed, is what I'm.
Right.
So sorry
Right.
to confuse you, but
No,
nonetheless, this was very relevant. So thank you for the presentation.
thank you. Sure.
Okay,
Thank
great.
you, Dr. Art. Yeah. Dr. Maria.
Yes, Sumajit, I think that I'm saying their name right.
Yeah,
Great
that's all right.
presentation. Actually, this topic, super relevant. I think that very, very important, because sometimes most of, scales that have been developed through time, not just scales, the scoring, etc., have always been under consideration for the US. And lifestyle, diet, habits are different from country to country. And I really, really love this topic. Couple of questions, couple of feedback, and I think that you can improve actually the study so much and to move forward if you continue to, to work on it. I think that it will be a nice part of your portfolio if you continue with this topic. But maybe I missed it, but I did not see any additional confounders that you added, while collecting the data. If there was like, I know that in some countries, the diet depends on the region for each country. Let's say that if they live by the coast, they live by the mountains, or even, religious type, or, access to food, deserts, food deserts, etc. There are different confounders that can be addressed, like while you want to collect the data, so are there anything that you that you identify that might be possible confounders where you collected the data for this research?
Well, there is. Firstly, it is important to note that our study was conducted at a specific medical college in India, southern part of India, and hence the results may not be directly generalized to the other regions or healthcare settings, even in such a vast country like India. And the demographics and physical characteristics of the study population may have had, also vary in different parts. And additionally, the accuracy and precision of the weight estimation methods may be influenced by, factors by uh, such as experience and training of the healthcare practitioners involved. So yes, these limitations, I guess you're right, should be considered while interpreting the findings of our studies.
Yeah, perfect. So a couple of feedback that I have on this one, like you mentioned, right? So it's a very limited study. So you may want to increase the number of population, increase the the demographics of your population. I think that you'll do very good if you do this. Also, I think with pediatric population, it's very good to include C-scores rather than just height and weight and then calculate BMI, and also percentiles. I think that will, for data collection, good, you collected this, but when you want to present your data, it's very good to do it with C-scores and percentiles because you're talking about a pediatric population. So that will be something very important. Now, why did you not include patients from 0 to 12 months of age?
Hello, Soumyajit, can you unmute?
I'm really sorry. Can you repeat the question once more?
Yes, of course, of course. So I don't know if you catch me when I said about the C-scores and the percentiles.
Well, during the ages you mentioned, there's rapid growth of the height and weight. So I guess it wouldn't be really beneficial if we only focused on that age group or that weight group. Hence, we also the Popper scale is used for 18 years. Hence, we conducted it from 1 to 18 years old.
Okay. So on that, like I was trying to mention, I think that it would be good if you add the population from 0 to 12, because that period of growth is very important for pediatric population. I think that most of the intellectual and physical growth have, it's impacted during that age as well. And like what I mentioned before is that when you want to present your data for pediatric population, although you collect data as height and weight, it's good if you present your results as C-scores and percentiles, because this is how we do it in pediatric populations. Just a take back on that. From the question that Dr. Shah asked you about why including, patients from 12 to 18, I think that the opportunity here is that if you want to start to develop a new system of registering the scales for, a certain population of a certain demographic, you also want to, have a big range of collection, because this will be your comparison. Let's say that you have a sick population from 12 to 18, they're still considered pediatric, but this will be your reference in the future, right? So this will be your point of reference to compare with sick patients that have like a dietary or a metabolic disease, right? So I think that it was a good idea to put on this population just to use as a reference, but always use as a starter, ages 0 months old to 12 years old as your starter. But yeah, it was a great presentation. I really love the topic.
Thank you. Thank you so much.
Thank you, judges, for the suggestions. And I think the audience question is already been answered. Thank you, Somyajit. And judges, I would ask you to write down the scores, please. And the next presenter, we have Samhita. If Samhita, if you can share your screen.
Yeah.
Judges, are you ready for the presentation? Okay, Samhita, you can start now.
Am I audible?
Yes, you're audible.
Okay. Hello, everyone. This is Samhita, and I am an international medical graduate from India. And today's topic for presentation is efficacy and safety of adavosertib in platinum-resistant or recurrent ovarian cancer. And my co-authors are Pavan Kumar, Nikita Yadav, Purva Shah, Prabhat Paudal, Pavan Kumar Reddy, and Madiha Subhan. And my PRMP number is 326. And I'm from Great Eastern Medical School and Hospital. Okay, so as we all know, ovarian cancer is the second leading cause of mortality in women with gynecological malignancies. And unfortunately, a lot of ovarian cancers in the advanced stages, they tend to become resistant to the primary treatments, and the prognosis becomes very poor overall. One of the most commonly used drug for treating ovarian cancer primarily is platinum derivatives, like cisplatin, and usually they're given over like 6 cycles for 6 months, and they also have a response rate with survivals around 3 months to 10 years. So platinum compounds are primarily used, but eventually over time, what is happening is ovarian cancers are becoming resistant to the primary treatment. So we've thought that we would have to look for a second alternative or an effective therapy to treat patients in such conditions. And one of the drugs that we came across was adavosertib. So it is a tyrosine kinase inhibitor. As we can see
here in the picture. So it acts at WEE1, and it makes sure that the cell cycle is not progressed from G2 to mitosis. So that's where that's where it inhibits the cell cycle, and it has proven to be efficacious in treating platinum-resistant ovarian cancers. So for inclusion criteria, we've taken all the patients diagnosed with ovarian cancer on histopathology and who have been resistant to the first-line treatment. And we did our literature search on PubMed, Google Scholar, Scopus, and Hinari, and Science Direct databases. So all the we've excluded articles that have not been in English, not been written in English. We've included randomized control trials, non-randomized control trials, cohort and case control studies in the inclusion criteria. Our primary outcome was a survival of participants with recurrent or resistant ovarian cancer, and our secondary outcomes were evaluation of side effects of the medication. So all the descriptive and summary statistics that we have had, we've used it to describe the study's cohort, socio-demographic parameters, and adverse effects. And also the meta-analysis was done using random effects model, which was used to assess the association of adavosertib with overall median survival of patients. So the bias risk assessment was done using Robbins 1 tool for randomized control trials and Newcastle-Ottawa scale for cohort studies. So from the studies that we have performed, we found that the overall survival of patients who were given adavosertib is 14.71 months, with a 95% confident interval of between 9 to 20 months. And the data has been statistically significant with a p-value of less than 0.001. So which shows that adavosertib had a overall positive effect on the treatment of resistant platinum cancers. So among the side effects that we noted, the most common one was nausea, and as we can see from the table, it's around 69%, followed by anemia and diarrhea, which were around 60%, and diarrhea with 56%. The other side effects that we noted were thrombocytopenia, neutropenia, vomiting, lymphopenia, hypomagnesemia, and hypokalemia. One of the challenges that we came across was the high heterogeneity from the studies. So I conclude by saying that the meta-analysis shows that adavosertib has shown some promising effect on the patients with ovarian cancer. And the three common adverse effects that we noted were nausea, anemia, and diarrhea. However, the limitations were high heterogeneity, and we only had 3 meta-analysis papers. So we reviewers strongly recommend that more extensive studies should be conducted on the topic to strongly prove adavosertib as this treatment option for platinum resistance. Thank you.
Okay, thank you, Samhita. Audience, you can write down your questions in the chat. Judges, if you have any questions, then I request you to ask them. Dr. Aarti, Dr. Maria.
Yeah, I guess I'll start. Okay. So, great presentation, Samhita. Really love the topic. So I wanted to know if by any chance within the data that you collected, your review, was there any association of other causes of death that lead, to this time of survival for the patients, and or if the side effects that were mentioned were aggravating that lead to the cause of death while using this medication?
I did not really come across a paper that would prove it for sure that it was because of the drug or the adverse effects. But the papers did mention that even with platinum compounds, it's the same adverse effects. Even with the platinum, it's still nausea and anemia and diarrhea. But hopefully, but there was no strong association, like to exactly prove that this was it. So primarily they focused on the resistant, because whoever was not, participants who were not responding with 3 months of platinum were categorized into being resistant.
Great. Yeah, I think that your conclusion is it's accurate. There needs to be more studies on this, because we're not determined if the cause is using the platinum or using the adavosertib, right? So I think that I agree, and there are more studies that need to be included. Now, do you think that you can mention what would be the potential reasons that there was high heterogeneity of, within the trials that you included?
So sadly, because only 3 of the papers were meta-analysis, that is probably the reason why there was like a lot of dispersion of data. Maybe that was a potential reason, which is again why we would emphasis on more studies. But that's what I thought.
Yeah. So on this one, I would say that, always consider that it could be, what's the type of patient population that you are addressing, right? That you've collected data from. What are the variations on the usage of the treatment? That there's some different approaches that can be used in different centers. So that's something that also needs to be considered. And and how did they assess the outcomes? So always have those in consideration for this one. But it's a great topic. I don't know if Dr. Shah wants to continue.
Thank you, Dr. Kass.
Thank you very much, Samhita. This is, yes, very relevant because of the fact the platinum resistant ovarian cancer cases. So yes, the last question that Dr. Ekas asked, that's exactly the what accounts for the heterogeneity and the response. Were there other factors other than what is already known? Were there factors specifically looked at what could account for the response, or I mean the lack of response to platinum derivatives, and of course where the adavosertib works, obviously that is responsible. But do we think that the significant positive effect on the overall survival, as we said, there's a need for larger studies to be conducted to know if it is a true association of, true positive correlation in the overall survival. And in that case, the relapse and the severity, the staging, the timing of diagnosis, the lead advantage that we get with diagnosis, were there those factors that were working in favor of adavosertib, right? So do you feel like those could have played a role in us seeing this, the p-value is so significant, right?
Yes.
So those factors matter too.
Okay, sure. Yes, like Dr. Kaza said, probably more into looking more into how the outcome from each paper ultimately led to the conclusion. Probably would have to do more thorough research on trying to figure out what the original paper said, maybe more into that.
Was looking at, and the timing, the severity, the staging, and all of those factors would matter to give an undue advantage to adavosertib, right? Nonetheless, there is a need. So even a little difference is good, right? Thank you for this presentation.
Thank you so much, Dr. Shah.
Thank you, Samhita, and thank you, judges, for your suggestions. Audience, if you have any questions, then you can write it down. Thank you, Samhita. I think we'll go on to the next contestant. We have,
Thank you, everyone.
we have Mirza Adil. If you can share your screen, Adil. Hi.
Hi, good evening. Can you give me the host SS? Okay, now it's
Judges, are you ready for the presentation? Okay, you can start, Adil.
hi, good evening, everyone. So, due to low bandwidth, I have closed off my camera. So, my topic is systematic review on medication event reminder monitoring tuberculosis patients. So, team members are Purvasha, Ilha, Jayaprakash, LV Simanchalam, Dayanika, Vidhi, Tarun Suvari. On the behalf of all my team members, I'm presenting this over here. So, before going to that, we all are knowing about that tuberculosis is a very old age disease and it's creating a lot of panic situation, not only for any specific country, that is specific to all the worlds. So since in 1882, since it was developed, after that, we are working on that. And apart from this, 10 million people are getting affected by tuberculosis each year worldwide. And among these 10 million people, 1.6 million people getting die every year. On the behalf of that, since emergence and since developed this disease, whole the country is working on that. And one of the sustainable development goal target has been shuttered for the whole of the countries, and target is intended to decrease the 90% of these deaths by 2030. Apart from this, 80% of incidence of these diseases, we have to decrease it out by 2030. And and on the behalf of same, that previous to it, a lot of intervention has been done, and the first intervention has been done for direct observational therapy. In this, likewise, this has been failed due to the healthcare at a facility, and that was the HR, human resources not over there. That patient has to intake and the medication in the presence of any of the health staff, and health staff has to visit over there. So, in the lieu of this, one newer innovation has came for the 99 dollars. This was a low cost initiative, and whenever the patient is going to peel off that medication to engulf that, there is one of the contact number is free toll-free number is over there. So patient has to give a call on that. If patient is not going to call on that or not going to give a missed call on that, so that will give an SMS to STS, that is treatment coordinator, health treatment TB coordinator is over there. So that the health coordinator has to take the follow up on that. And this is also not got validated and not successfully in some of the countries. So that has failed. And now we have came with the MERM. And MERM is medication event reminder monitor, and it is a digital pillbox. And this increases the adherence of the medication, and adherence to the medication is going to reduce this drug resistance directly. And that is also going to reduce this mortality as well as the morbidity. So the rationale of a study is that. And apart from this, likewise, key treatment failure and relapse is going to be decreased on this. And this MERV is a medication box. It is considered. It contains 3 lighting over there, lighting indication. So the green indication is going to indicate that take the medicine, and the same is over there is yellow. Yellow is going to indicate you that he refill that medication, while the third one is that is red. Red indicates for the 2 parts. That is, the first one is not consume the medication. The second is low batteries over there. So, and one more thing I want to point out for the MERM is over here, that within the 72 hours, the data is going to be transferred with the cellular network to the server. So that is the good part, that the healthcare staff is going to be notified within the given the time frame that the patient has been not engulfed that medication, and that the healthcare staff has to be visit their home and take care of that to means that to engulf that medication within the timeline frame of 24 hours and then 48 hours. So that will obviously going to reduce this drug resistance. So while this outcome what we have measured for this we can discuss in the pre-course. So the next slide. So for this we have checked that PubMed, Science Direct, DOAJ, Embase, Web of Science, Cochrane Library, Cochrane, a lot of database we have searched. And for the PCOS, the population which has population with diagnosed with tuberculosis and age having about the 15 year, and we have followed that Prisma tools for this, that is preferred reporting item for this one, systematic review. And apart from this, we have used the search strategy effective to this, and we have also registered this in the Prospero. After this, search result has been resulted at 2,681, and we have reviewed the full paper 38. And after that, reviewing the full paper, we have come to at the end that we have included 8 papers. That is coming out the inclusion criteria, the cross-sectional cohort and case observational studies. And for the quality check part, we have used Newcastle Ottawa for the observational studies, and ROB we have used for this randomized control trial. So coming to the result part, that 8 studies has been included, and the total participant results to this one 76,811. And among these, the main part is that which we have to focus that 31% is female, and average age is coming under to the 44%. And apart from this, one more indicator I want to put out over here, like 3,725 people are who is only able to read and write. And when we are going to discuss about the physical quality of life index and human development index, this is directly going to affect all that one. So, at the final conclusion result has been shown that MERM is directly increasing the patient adherence medication, and which is going to directly reduce this drug resistance and the increment of medication treatment of the drug treatment period. And likewise, Zumi has also reported that the missed dose has been decreased by 20% as compared to the other parts. And also there is that urine isoniazid test has been resulted negative 5.5% times in the comparison to who the patient is going through the MERM. And adherence already has been increased, and significance is more sensitive as compared to the 7-day recall method is over here. So favorable outcome has been reported in this, while in the comparison of the other arms. So this is the final result which we have developed on this, and the majority part has been under the low risk coming over here. And so that's why we can recommend that MERM is over here, and this is directly going to help out help out the policy makers and decision making for the MERM, and to decrease the gap in existence average to take any of the final output and a call for the interventions. So the final conclusion is that likewise it has proven the boosting patient adherence and treatment success rate. It's over there, but where we can focus on that the method of follow-up which has to be updated somewhere. Likewise, feasible portion that is going to be input in the loss to follow-up. So some of the innovation and some of the intervention is required in the method of the follow-up. And due to this, we can increase out, and adherence will be getting more, and we can directly going to be this will be going to be the result. Thank you. Thank you. Over to you, panelists.
Thank you, Mirza. I would ask the audience if they have any questions, then they can write it down in the chat box. Now, the judges, if you have any questions, then you can ask the questions. Dr. Aarti, Dr. Maria.
Yeah, I guess I'll start. Okay, Mirza, really good presentation. I really love the topic. A couple feedback notes just from your presentation. So whenever you're presenting, you always have to consider that you may be using a lot of technical information that some of your audience may not be familiarized with. So during the first part of your presentation, it would have been nice if you break down the color coding of how the patients were follow up according to their adherence, right? Always consider that in a presentation. I was able to pick up what you said, but always think about your audience so they understand the information that you're relaying to them, right?
Got it.
That one. I like the methodology because you really explain where you obtain the data and how you compare it, and that you, you put it into Prospero, you registered. That's really great. What do you consider that, where the issues on maintaining these patients to follow up, and continue to do this questionnaire?
So likewise in the MERM, so when the red light is going to be obtained or received to the STS and the treatment coordinator is over there, so that the follow-up requires some of the intervention that some of the health HR should be over there. So directly that has to be followed within the time frame and without getting delayed. So that will affect that medication. And likewise, some of the studies showing that in the latent TB, so if any of the patient is missing that dose, that is 33% if dose has been missed, so that has to be excluded from the study. So that should be not over there. So we have to modify the follow-up on this. If any of the treatment coordinator is getting notified that the dose has been missed, so he or she must have be contacted at the same time within the time frame of the 72 hours.
Well, it's always something that needs to be considered in these trials. I agree.
Yeah.
By excluding patients that cannot read and write, you're excluding a big important part of the population that might be mostly affected. And also using mobile devices, I think that, there are alternatives nowadays that we can do, like, contact the patient, and in small centers, you can use, community service, community medical attention. But I agree.
Yes, adding to this, likewise, that you have said that for the community intervention of the lower parts. So likewise, when in the first slide, which we have shown that over here, when the dot and 99 dots has compared, that has been initiative has been taken on the community level. So that has been failed over there. So that's why we are coming towards the medical event reminder.
I agree. Yeah. Also, there was always to consider when loss of follow-up in this data collection. It's death and hospitalization. These patients can always be a loss of follow-up, consider a loss of follow-up, because they have not been able to complete the collection of data by themselves, because they're either hospitalized, they move to another region, or they passed away, they died. Also, at the last slide where you presented the results, it's good to always highlight the most important questions and not just put them like question 1, 2, 3, 5, 6, 7, but always highlight what were, the most important part of the results that you obtained from these methods. But really good presentation.
Got it. And adding to this points that some of the migrants over there. So in the MERM, there will be option that in the worldwide level that medication will be given and provided even any of the sites. So he or she can show their cards, and that can be if the medication they will be received. And this will also reduce one of the phenomenon likewise in the previous two is that the patient has to be come at the facility level and to get that medication, and due to some of the social stigma, it is not followed in some of the rural parts. So that will also going to be reduced.
Okay, great. Thank you for answering my questions.
Got it. Thank you.
Thank you, Dr. Maria. Dr. Aarti.
Yes, thank you for a great presentation, and very relevant, as are so many of, or pretty much all of the topics presented today. But obviously the community impact that this can show and the importance of adherence, right? So following up on what Dr. Ikaza was mentioning, what is the advantage that you see this versus the 99 dots and the, preceded by the dots? What is the significant advantage? And if in the conclusion you feel that there is a adherence, the loss to follow up was impacting the, was adversely affecting the public health significance of this, then how are we, getting any advantage over the 99 dots?
So 99 dots has been started implementing in the year of since 2015, and in the 99 dots there is one of the concept that the patient has to be give the missed call on the toll-free number, and if the patient is not if the patient has not taken that medication, so the STS, that the treatment coordinator will got the message on that the patient has not taken the medication. So this STS has to visit their home. Likewise, in a small hubs, likewise, we can consider that under the patient, likewise, in the one STS is having a patient of 200 people, and 3 or 4 patient has been not taken the medication, so he or she has to be visit their homes. So that was the failure because of the low human resources at the sites of the at that site. So that's why that has been reduced, and now we are coming with the MERM. And the relevance with the MERMs is that the study is showing that adherence is higher in this, and easy to take, and likewise this is directly affecting on that 1.6 million death and that the morbidity. So relevancy of this study we have found in several studies, and so that's why some of the several countries have been taken on that, and some of these, likewise the union is implementing their clinical trial with the mom on HIV and pediatric TB as well.
Okay.
In Delhi as
So
well
what,
as going.
Great. So what I understand is there are already existing data, excuse me, that shows that the MERM has a significant public health advantage despite its limitations of loss to follow-up. And the loss to follow-up is because, as we said, if they move, they can still utilize this. But if they are, hospitalized, or if they don't have access to the cell network or what have you, or a complication of the illness causing death, then those are the cases which are being lost to follow-up. But overall, it has significant advantage because the adherence is overall maintained because of the lack of human resources, especially I'm thinking in the last 5 years, some of which was related to COVID. So that was making the 99 dots, putting that at a disadvantage, and we're trying to get a middle path between the two. Is that right?
Yes, ma'am.
Okay. Okay. Wonderful. Thank you very much. This was very
Thank you, ma'am. Thank you.
Thank you, Dr. Aarti. Thank you, Mirza. Audience, if you have any questions, then you can write it down. Okay, thank you, Mirza. The next participant is Sujaya Chattopadhyay. Unfortunately, she is currently traveling, so she is not present, but she has shared her presentation video with us. So I'll ask Dr. Abdul to start the video.
Yes, thank you, Jill. I'm sharing my screen and I'll be playing the recorded video.
Thank you.
Hello, good evening. I'm Dr. Shujaya Chattopadhyay. I'm here on behalf of my team at the second ISCI Annual Conference Research presentation to present our systematic review. A very warm welcome to everyone present here. Our topic is mainly clinical outcome of established and promising treatment modalities of monkeypox, a systematic review of case reports and case series. Before I delve deeper, a few words about my team. I'm Dr. Shujaya Chattopadhyay. I graduated with an MBBS degree in the year 2021 from Kolkata, West Bengal, India, and I'm currently working in the Department of Medicine in West Suffolk Hospital, United Kingdom. About my co-authors, Dr. Purva Shah was our mentor. We had Dr. Aisha, Dr. Ikra, and Mrudula, which made it an international collaboration between India, Pakistan, and some doctors being in the USA as well. No conflicts of interest were declared amongst the authors. Coming to the introduction, it obviously begs the question, why did we choose this particular topic amongst a myriad of other topics that probably deserve attention? The reason is definitely the emergence of it as a public health concern last year, when WHO had to declare it as a public health emergency because there were sporadic cases and even mortality all over the world. Moreover, from a clinical point of view, there is significant overlap between monkeypox and other viruses of the poxviridae family when it comes to the clinical symptoms and signs, the prodromal features, and even the management and the treatment. So that's how we have designed our primary and secondary aims, which are elucidated here. And probably the gap that we're trying to address here is to compile specific, accurate, and precise data regarding only monkeypox infection and not any other virus, which would be the need of the hour. Coming to the literature review, we saw the major databases and followed the typical mesh keywords and Boolean operators. Highlighted in green is our inclusion criteria, highlighting in red is our exclusion criteria. Microsoft Excel is the main tool that we use for data collection and analysis. The statistical tests are the ones that are mentioned here. Some of our data was heterogeneous, for which we use the ISCI method as well. The JBL provides separate critical checklists for case reports and case series, which were the ones that were utilized for quality assessment and risk of bias assessment of the studies. And this is how it graphically looks. If we look at the legend below, then it becomes quite clear the nature of the studies that we were dealing with. Coming to the results, we selected 31 case reports and case series after following the Prmp flowchart of identification, screening, and inclusion, and doing the necessary elimination for duplication, not fitting the criteria, etc. The demographic factors like age had some missing gender data. Antiviral treatment, coming to our primary aim, antiviral treatment definitely had a positive correlation. Almost no patient received antiviral medication, which culminated in a bad outcome, whilst a significant proportion of the patients received one antiviral medication and had a good outcome. Coming to the specific antivirals, tecovirimat definitely has an upper hand, but it was difficult to gauge the relative superiority of the benefit because we didn't really find a very significant association between a good and a very good outcome. On overall, we found that antivirals definitely had a positive association, but when we adjusted it for other demographic and clinical factors, the significance was lost. This is how the chart looked like when it comes to the maximum likelihood estimate utilization to determine the influence of the factors on good patient outcome. We have already discussed the antiviral treatment. Smallpox vaccination kind of follows a similar chart, being positively correlated but not having too much significance. Age, on the other hand, shows that the p-value is less than 0.05, which probably means that adults would fare better in the infection than children, and that is something we found in our outcomes as well. Pediatric mortality was more compared to adult mortality. Males are supposed to fare better than females. That's how the negative correlation can be seen, but again, it's not significant. Most interesting is the tail enders of the table. Immunodeficient status shows a positive correlation, which is very surprising considering the exact nature of the term, but can probably be explained by the fact that every HIV patient, every disease contributing to immunodeficiency was considered under the umbrella term, regardless of the fact, even if they had a controlled viral load, even if they had undetectable viral load. So that is something that can account for the paradox. Coming to the HIV medication, it shows a negative correlation, and that can easily be explained by the fact if we consider HIV medication to be a proxy of advanced status of the HIV or AIDS disease. We can take it as as an indirect indicator of advanced HIV disease of uncontrollable viral load. And that can explain for this paradox that arises at the tail end of the table. To conclude, we would definitely say that antivirals, especially tecovirimat, although has a bearing on patient outcomes, but we still need more robust evidence to prove that it is a very determining factor for patient outcomes. And that again begs the question, do we need to consider primary prevention before secondary treatment for monkeypox? Would public health measures, would awareness, would health education be more important? Would stabilizing the patient be more important than administering antivirals? Because obviously the association has not been significant. So more education, more research, more investigation into this genre would definitely be the need of the hour and show the path forward. So thank you on behalf of my team. It's been a pleasure. Thank you for having us. We are grateful for this opportunity. I acknowledge all my team members and ISCI for this chance. Thank you.
Thank you, Abdul, for the video. As Sujata is not present, so we will not be having any question and answer session for her. So I request the judges to score on the basis of the presentation alone. So here we are at the end of the presentations. So until the judges and Dr. Abdul and Dr. Tejas analyze the scores and tell the winners, it's time for the PRMP awards. So I would like to invite Dr. Purva to present the awards. Over to you, Dr. Purva.
Thank you so much, Jill. And I hope I'm audible. My internet is a bit unstable, so please let me know if you're not able to hear anything or see the slides. And thank you so much for all the participants and all the judges to sit through 2 hours of back-to-back research projects. So here we go. Today, we are going to talk about PRMP awards for this particular rotation, Jan to June 2022 rotation. It was a 6-month long rotation, which ended up becoming a 1-year long rotation. And today we saw all the papers of this particular rotation. This is just a brief history of PRMP. The first rotation was from August 2021 till December. And then this Jan to June 2022. The number of participants, it's exciting to see that the number of participants is increasing. The number of mentors are increasing. The reason why mentors are increasing is because we have a rolling basis of mentorship. So all the mentees that we are teaching right now, they will become mentors in the next rotation so that we can reach as many people as possible. Moving to the next slide. We have 4 main awards. So the first one is Best Mentee. We take into consideration their interest in taking responsibility. From the entire group, for each task, we assign a task leader among the mentees. So whoever takes up that responsibility is given brownie points. Then attendance in group meetings. If there is no delay in responding to text messages, ability to meet deadlines, ability to grasp new knowledge. And then some quantitative measures for which we take into consideration the published papers, presentations, and also very importantly, if that mentee has taken up any mentorship role in a future rotation. At the moment, we are going through our 3rd rotation. So if any mentee from the Jan to June rotation got mentorship in this one, so that is something that we consider. And of course, interest in taking leadership role. So we have our deputy directors and directors with us today as well. These are the strong contenders. So we have Siddhant Ochani, Ramsha Abdul Qadir, Lajja Gadvi, Sakshi Manglik, Ali Nawaz Khan, Sumaya Wasim, Soumyajit Das, Shankhnil Ghosh. I believe most of you are present today here. So welcome to the PRMP Awards. Asma Khan, Kaushambi Chauhan, Jeel Patel, Pratma Bidwai, Abdul, Anand Siddiqui, and Khushi Ochani. So these are all the strong contenders. We went to each mentor and asked them to provide names and some comments for each of these mentees. And after taking into consideration all the points, we have 3 winners, 1st, 2nd, and 3rd position. So 3rd position is for Lajja Gadvi. She takes up initiative, and for any particular task that is given to the team, she is the first to message, can I do that? And can I take leadership for that? So thank you, Lajja. The second position is for Asma Khan. She makes it a point that the mentor is on time. She makes it a point that the project is not delayed. She keeps on messaging, what is the next step? What is the next step? So because of that, it is very important. And then the first position, we have Siddhant Ochani. So at the beginning of the rotation, he was a mentee. And towards the end, he developed so much knowledge that he ended up teaching all of us some new points about meta-analysis. That is the type of study he was participating in. Congratulations, everybody. Moving on to best mentor. So some of the criteria for judging mentors was first, if they were interested in creating learning material, be it PowerPoint presentations or sending some course materials, YouTube links, and their ability to adhere to the timeline that was provided to them. And of course, effective communication, attendance in monthly mentor meets. We have monthly meets to teach mentors or just solve queries. And later, number of mentees from that particular mentors group who became mentors in the next rotation. So that is also something we consider. And then quantitative measures, like I mentioned previously, we have published papers, presentations, and yeah, if the mentor got into a leadership role, that is also something that we take into consideration. So these are the strong contenders. We have Dr. Binish Aslam, we have Dr. Vivek, Pratik, Rama, Nabila, and Saurabh. All of them are present for their mentees. All of them are always forced to join in mentor meets, and they all have successful publications during the deadline provided to them. So the winner of the Best Mentor Award goes to, Nabila Fatima. She's unfortunately not with us today, but congratulations, Nabila. We will send a message to her as soon as possible. The third award is Best Research Project. So we mainly take into consideration quantitative measures like the quality of evidence that is there in the evidence-based pyramid, the originality of topic, just like Dr. Aarti and Dr. Maria mentioned that the pediatric paper was a very good topic, and of course the tuberculosis one. So we definitely take that into consideration as well. And then timely completion of project. For this particular paper and for this particular award and the next one, we have taken this very seriously. And then, of course, the impact factor of the journal, quality of conference they have presented their paper in. And these are some of the strong contenders. Majority of Jan to June papers, from them, case reports and short communications, and there was one narrative review which was published. And today, all the papers that you saw, systematic reviews, meta-analysis, original studies, they are yet to be published. So hopefully they will be considered in the next awards. So we have these groups 0 to 15, 0 to 01, 0 to 12, and 0 to 03. These are some of the pictures from today's presentation, but they are just notable mentions here. And the best research project goes to 0 to 15. So Saurabh Karki is the mentor of this group. They have presentations, they have publication in the year provided to them. And they were the first publication in the Jan to June rotation. So they actually motivated other groups to work fast and submit their papers. So congratulations, group 0 to 15. Now, the last award, the best PRMP group. Mainly, we are looking at teamwork here, communication, ability to just motivate each other, feeling of belonging to the team. And for quantitative measures, we obviously look for the previous considerations, that's published papers, presentations, etc. And the nominees are 3 strong contenders. One is 0 to 12, that is Rama Alkaldi's group. Then we have 0 to 01, Nabila Fatima's group. 0 to 15, Saurabh Karki's group. So you must have seen these names in the previous awards as well. It makes sense that these are the strongest groups of Jan to June 2022 rotation. And the best PRMP group goes to 0 to 01, Nabila Fatima. They have several papers to their names and they are doing amazing. Amna Siddiqui, one of the mentees, has become a mentor. And we have Prakyat Srikaram in our following rotation. So congratulations, everybody. Really, really happy to have you with us. Over to Abdul to share the paper presentation competition results.
Right. Thank you. Just give me a minute.
Sure. Dr. Aarti and Dr. Maria, would you like to say anything about today's presentations? Just a general note for our participants. Dr. Aarti, you're on mute. I'm so sorry.
I was saying I'll actually let Dr. Ikaza go first because I've been putting some notes in the chat. So Maria, would you like to?
Sure. So first of all, thank you very much, Purva, for the invitation and participating in this program. Congratulations to all of the contenders. I believe that, having an initiative like this in which you can all collaborate in research, I think collaboration in research is a must, and is something that, will improve your odds for whatever you want to continue within your career. If you are taking the steps, if you are taking the PLAB, etc., I think that collaboration, it's always the best, the best way to approach research. Whether you are just entering, you're on, you don't have a lot of knowledge of how to start, or whether you're mentoring other groups, I think that this is the best way to do it. And I think that the organization that you guys are running, it's bringing up all those outcomes for the participants. So I think that that's really great. And thank you very much again for inviting me. Hope to see you guys again soon. And yeah, congratulations to everyone.
Thank you. Thank you so much.
Yes, I agree with all what Dr. Ikaza has mentioned. And as I was entering in the chat, each and every one of you is inspiring, not only yourselves, but others and your mentees as well as mentors with all due respect, because as we learn what has been done, what needs to be done, and what could be done better, we have a perspectives, and then we are trying to have a healthy discussion, not only here, but when you're having that in your own little communities and what have you. But most importantly, it's eventually benefiting the community, our patient, our population across the world, and then the global impact that we have, because we are learning across the world, as the pandemic just proved. What many countries can learn from others, it's not dependent on socioeconomic strata or where research has been published more, but what research needs to be done more, and the disadvantaged population, so to say. So we are their advocates, and I'm so thankful to each of you who's not only doing this for yourselves, but eventually we are all in this for benefiting the community, right? What we got into becoming medical professionals was our hearts in the right place, and we want to use our brain and merge the heart and the brain together, because the doctors and all of the medical students, the prospective budding doctors, need to show to the world and themselves that we are the ones who are the scientists, along with obviously all the other collaborators, whether it's pharmaceutical companies, vaccine manufacturing companies, obviously our community workers, the social workers. It's a collaborative effect with our nurses and everyone. But we do need to show that we are very relevant stakeholders, and we're not working in silos, only in our clinics and only in our communities. But we want to share that research and be still heard and known, because that's what's going to help our people, our community. So thank you for what you do.
Thank you so much. Thank you so much for your kind words. All right, then we have the results with us. And Abdul, would you like to share the results?
Yes, so this was an amazing session, and I would like to thank both of our judges and all the audience for being here with us. And all right, so we have compiled the results, and we have a first place, we have a second place, and then we have a third place. And surprisingly, on the third place, there are 3 contenders actually. So we have 3 ties for the third place. I'll start with the people who actually got the points and they had a tie on the third place. So it was Asma, then it was Adrika, and then it was Samita. All 3 of them scored the same points and they had a tie for the third place. So congratulations, guys. You guys did a very good job. And then for the second place, we have Dr. Ramsha. She was able to score just by a slight margin. She was able to score more than all the presentations which were at the third place, and she has secured the second place. And the first place goes to Dr. Mirza Adil, and he also actually won by a very small margin, but for sure his presentation was very good. And as the judges said, they actually liked what he was talking about, and his content was very relevant, and his questions and his answers were also very relevant. So congratulations, Dr. Mirza. Is he here with us right now, or has he left? I think he has left.
I'm here.
Oh, you are here. Yes. So congratulations, Dr. Mirza.
Thank you. Thank you.
Thank you so much, Abdul. And congratulations to the winner. I now invite Jill for the vote of thanks.
Thank you, Purva. So we were really happy and grateful to our judges, Dr. Maria and Dr. Aarti, for sparing their valuable time for us and gracing this event. Your suggestions, I'm sure, have been really well helpful, and we have learned a lot from you today. Thank you so much, both of you, for gracing this event. Thank you.
Thank you. This was our pleasure. Thank you.
Now, thanks to all the hands that contributed for success of this event. A big round of applause to all the organizers, Dr. Rohit, Dr. Abdul, Dr. Maliha, Dr. Tejas, Dr. Kathir, Dr. Ananya, Dr. Anjali, Dr. Poojan, Lalita, and Dr. Manu. Thank you. And it has been a great effort to make this conference a huge success. Now, I would also like to thank our partners for the conference: INOS International, ReMed, Auto Research Initiative, Boston Congress of Public Health, Med Student Network, Medellins, Project IMG, Fellows in Medicine and Research, International Journal of Medical Students, Lexicon Magazine, Global Neuroscience, Global Association of International Medical Students, International Association of Student Surgical Societies. Once again, I would like to thank each and every one of you, and I would take a leave with a very